This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hello, and welcome to another episode of It's Not In Your Head podcast. I am your host, Justine Feitelson, here with Dr. Dan Bates. Hello, Dan.
Hey, Juz. How are you?
Good. How are you?
I'm up and about. Here we go.
Ready to go. All right. Last procedural episode for this season. We are going to get into my personal favorite, neuromodulation. This is a really, really interesting one if you live with complex pain or CRPS, but we will take a deep dive into what other pathologies this is used for, what to expect as a patient, how do you get all the way to permanent implant, and what these esophaguses are all about.
Oh, reference.
It might get cut out. We'll see it.
Okay. All right. So disclosures first. So I have a number of disclosures in this area that are across research that I've done previously and then both teaching and consulting for certain companies. So firstly, from a research perspective, I've done research for Nevro, Abbott, Saluda, Biotronic, Presidio, Nalu. Is there anybody else? I think they're the majority of companies that I've worked with from a research perspective. I've done teaching for Abbott and Medtronic on a semi-regular basis, which is both teaching how to do procedures, but also how to do implants of spinal cord stimulators. And I've also done some consulting for both Medtronic and for Abbott. So take that as you will. You can not listen to anything else I've got to say or take it with a grain of salt, but they're my disclosures you all need to know about. From the perspective of spinal cord stimulation or neuromodulation, it sits within the context generally of managing neuropathic pain. So there is an episode that we have gone through on the management of neuropathic pain. It puts it into a larger context that is not just, hi, we have a device, we're going to stick it in. So
yeah, you check that's episode 17, Dan, nerve pain
fantastic.
management.
And so so this is effectively a subset of that episode. And so when you're looking at managing somebody's neuropathic pain, firstly, you're identifying that they've got that. You're going to be taking them through conservative management strategies. You're then looking at your medications, which is your first line medications in the forms of amitriptyline, gabapentin, duloxetine, and pregabalin. Then into your second line medications and then interventions. So the interventions are then, injections and pulsed radio frequency and the like. And if you're then at the situation where you have not had any progression with your therapy, then you're starting to look at options like neuromodulation. Now, one of the things I do want to point out is that for people with neuropathic pain, going through that whole process, if you've worked through all the anti-neuropathic medications, there's still a 50% likelihood that you haven't gained an improvement in your pain, just based on the way the numbers needed to treat work. And so your number needed to treat, just once again, is the number of people you need to treat to get one person better. And if you do the math across all the medications that we have, 50% of people still have no response to therapy, or at least minimal response to therapy.
Not good enough response to therapy.
Not good enough is probably the best way. So neuromodulation acts as an option for those patients. Now, it is not a cure. It is part of an overall treatment strategy that you combine with medications, with psych, with conservative measures, with exercise, with rehab to get your pain under control.
Yeah. So even though it's the last house on the block option and it's like the big kahuna when you're in that situation, it's still not going to take away everything. And you still have to do all the other stuff. It's still a tool.
It's not a cure. And that's important to understand. Unfortunately, which I find this part interesting, when we turn on neuromodulation, it helps settle somebody's pain. But when we turn it off, the pain comes back. Like, why is that? Why does our nervous system behave that way?
Right.
Where it learns everything else, but it's not learning the pain-free state. That's a interesting
separate side quest
process and
episode.
Discussion for some other time.
Speaking of that, though, Dan, what are the different frequencies or the ways that neuromod is actually utilized? Do you want to get to the types first?
Yeah. So there's two ways we think about neuromodulation. You can think about neuromodulation from where the leads are placed. So you can place the leads along the spinal cord, and we place the leads at the back of the spinal cord where the pain fibers are running. You can place the leads out in over the nerve roots. And so you're capturing the pain fibers as they're passing into the spinal canal at the nerve roots. And then you can place them out in the periphery. So out on the peripheral nerves that are supplying arms, legs, and backs to then decrease pain at that level. The other way you split it up, you just split it up into the waveform. And so if you look at all the different companies that are around the world, they effectively have different waveforms, which is a fancy way of saying they have different ways of making the device buzz, which then alters the patient's pain. So we will split these into, depending on where you are in the world, low frequency and high frequency. The definitions of high frequency vary depending on parts of the world. So high frequency in sort of Western nations is thought about as 10,000 hertz and above. In Asian nations, it's actually greater than 1,500 hertz is considered to be high frequency. So there gets a bit of a mismatch in language depending on where you are when you're talking about these things. But, you know, for this conversation, low frequency is essentially not 10,000 hertz. Right. High frequency is 10,000 hertz. So each different company has a different waveform. So I think if we just focus on high frequency first, so high frequency,
what are the high frequency options?
Is a company known as Nevro, and it buzzes at 10,000 times per second and helps decrease pain. It has a different mechanism of action to a number of the other companies. There is then Abbott that has what they refer to as burst DR. The DR is named after Dirk de Ridder, who's the neurosurgeon that developed and designed this. And it's a physiological waveform. And so they're looking to match the way the nervous system works to then alter pain. And it looks like that system affects two different pathways. So it affects the medial pathway that affects emotion and the lateral pathway that affects the noxious stimulus like the ouchie part, and it down regulates those pathways and helps settle down pain. There's then a range of other systems. So Medtronic has a system they refer to as DTM, which is differentiated targeted multiplex. And what they're doing is they're running multiple waveforms at the one time. And in this setting, they're targeting, in part, the support cells of the spinal cord, which are called microglia and astrocytes, as well as targeting the nerve function itself. That essentially is similar to the issue around low frequency. It is two low frequencies running at the same time. Nalu runs a different waveform, which they call, I think, a powertrain, which is just multiple frequencies running at different time frames. And each one of these frequencies essentially are altering the way the nervous system responds to stimulus, basically. And so they decrease patients' pain. There hasn't been a whole stack of studies that will compare one to the other. So there's not really high frequency versus burst. There's not
versus low.
What there is there is low frequency, which is considered 30 to 50 hertz, that is being compared against high frequency. So low frequency is also known as tonic stimulation, and that's the main comparator that has been used in most of the studies that look at neuromodulation. Depending on what system you're using, you will then consider what is the best thing to be treating. So there are different types of neuropathic pain. So neuropathic pain you may be considering is post-surgical neuropathic pain. Most of the companies have got randomized controlled trials in that group. So essentially post-surgical back pain is the main target for many of the companies. Abbott has done studies in using dorsal root ganglion stimulation, and they have particularly targeted a complex regional pain syndrome. The thing about that system is it allows you to target specifically the nerve roots, so that if you have a focal area of pain that you may get with complex regional pain syndrome,
Right.
that allows you to specifically target those nerves, which is what Jazz has had before.
Is that part of why when you have CRPS, the DRG seems to be more preferred and has a little bit better research compared to the classic spinal cord stimulator? Right. So again, not all neuromod is the same depending on the pathology you have. You're going to want to veer more traditional versus DRG. And then within those, potentially have a conversation around frequencies if one even can. But as a patient, I don't know that comes up from the patient side. That's something the clinician is aware of.
That's what we're thinking about.
So you're not going to them with those questions, but you should be approaching them as far as SCS versus DRG versus peripheral, why or what are we doing? Yeah. It's interesting.
And then there's peripheral stimulation. So that's where you're placing leads underneath the skin and you're targeting the nerves in those areas. And so a lot of the time we'll use this if you have very widespread pain that we can't isolate or bring down to. The other times that I'll use this is in the setting where, we may have done a spinal cord stimulator trial and haven't been able to capture the pain. Or if we're doing something like you're managing somebody with shingles that has got persistent pain post-shingles, where what you might want to do is place leads on either side of where the shingles pain is and try and down-regulate it that way rather than doing it with spinal cord stimulation.
And that's a less invasive option than the traditional SCS as well as the DRG.
Yeah.
So.
One system I should mention, which is an Australian system that's been developed by Saluda, is a system that uses low frequency stimulation. And what it does is they measure function of the spinal cord. And so what they're doing is they are stimulating the spinal cord. They are then measuring the change in the response, correct, in the spinal cord. And then they alter the next pulse based on the previous pulse. And so you're looking to get it into a specific dose range.
Yeah, that's cool.
And they're using low frequency stimulation. So it's buzzing between 30 and 60 times per second. And they are changing the neuromodulation each time. And so that's a system that's got excellent data that's been published now. I don't consult for them. I do research with them, but I don't consult for them. And I do like their device. It's the one we're using most at the moment because it does have I would consider the best data set at the moment. And I think we'll probably continue to use them until somebody else has got the next best data set, which has been the way we've moved over the years.
Yeah, well, and that's a good example of how much spinal cord stimulation technology has changed over the years compared to when they first started doing this. And some of my patients that have implanted earlier, right? I had mine put in like 5 years ago, and then what is coming up and available in the future keeps getting better. So
but this is a very, very old technology. So this started in 1965. So first spinal cord stim was done
a
in
lot
1965.
older than people realize.
Yeah. So it's gone through, a large period of time of development. Yeah. The biggest change really came in 2010 with Nevro coming onto the market because they came in with what's called paresthesia free. Yes. So when you have low frequency, you can actually feel it buzz.
And so it's like the tingling all the time. Yeah.
It gives you this, what we refer to as paresthesia, which is supposed to be this nice sort of feeling in the area that down-regulates the pain.
Nice feeling, said anyone who doesn't live with it. Nice feeling.
Yeah, so Jazz doesn't like it.
I don't live with it either, so I can't totally, but I would rather have no sensation. Well, you like it from the perspective of, I'm getting the pain relief. It's kind of distracting. It's like a TENS unit. It can feel nice to feel something other than yourself, or like cupping is nice in that way. So I can get why the sensation is pleasant.
But there's been plenty of studies done on looking at people that the proportion of people that prefer paresthesia versus
it's just personal preference.
But no, never always was the big change. So they came out with the first product that was paresthesia free, which then and with their high frequency they changed mechanisms, and so. Yeah. And then after that, Abbott brought out Burst DR as a paresthesia free, and then everyone.
Then you start getting competitors, with that.
So that's
exactly.
So spinal cord stimulation is it's a process.
What is that process from consideration to implant?
you want to work through it, your first line, second line treatment strategies. It wants to be done in a multidisciplinary environment. So it's not just, put in the stim, see you later. It's, it's about incorporating your rehab, your psych, your medication management, moving into neuromodulation. And then once again, it's kind of then working in reverse, decreasing your medications as you increase your rehab. And then from time to time, because your physiology changes,
right,
that means the stimulation changes.
Yeah, your body adapts and gets used to the stimulation.
Exactly. And so from time to time, you need to come back and you do this process called reprogramming, which is where you either turn it up, turn it down, or move the position that the stimulation is taking place to recapture pain relief if it gets lost. And so it's not a static one and done, see you later.
It's not completely set it and forget it. Yeah, it feels like that, but come back. Yeah.
It's come back from time to time, redo the process. So within that multidisciplinary environment, you are then going to go through a trial first. So a trial is where we place leads along the back of the spinal canal. They come out of your skin, we suture them down and then stick them down with a bunch of tape.
Yep.
Yeah. And you walk around.
Battery stays on the outside for the trial.
And you walk around for a week and you see if you can decrease the pain. Okay. And so what we're looking for, a positive trial is technically 50% decrease in pain. I personally would like to see people get 80% decrease in pain, because if we only achieve 50%, by the time you get 12 months down the track, that 50% is not good enough. And because you get changes in your perception of pain, and people end up being unhappy about it. So I really want people to be able to get an 80% decrease in their pain. And hopefully we see during the trial that you get improvement in function. So you can walk a bit further, you get a bit more social, you can go out and, maybe go to dinner with your partner. And you know what? And a lot of the time when it's a very positive trial, family and partners feedback, hey, they were much happier this week. They were blah, blah, blah. And so that sort of composite where you're having social improvements, pain improvements, hopefully decreases in your pain medication.
But does your sleep improve, right? Like your these things that pain makes hard.
Yeah.
So even if, yes, you want pain to improve a lot, but does your function and the other context pieces?
But if you get a 50% decrease in pain and nothing else changes, I'm like, I'm not keen on that.
Yeah.
So if you do have a positive trial, pull the leads out. Generally, you come back 2 weeks after and place the leads. So this time the leads are placed into the spinal canal. They're tunneled underneath the skin, and they're then connected up to a battery, or an IPG. So that IPG will be two types. One will be rechargeable or non-rechargeable. The non-rechargeables are effectively that non-rechargeable, and they will last for 5 to 6 years on average. For the rechargeable devices, they probably last for 7 to 10 years, and you recharge them anywhere between. It's interesting. A lot of the numbers have changed recently, but it's anywhere from every day to, for some patients, they're now just charging them once every 3 months. It's quite amazing, actually.
Is that a different device? How are they getting that much time?
Yeah, so a lot of that's coming from the high frequency stimulation. Also, and they've really dropped their dosing down to say 3%,
because then it doesn't wear out as quickly,
and so you don't have to recharge it so much. There's been some new battery technology come out with Abbott and their devices, and so they're recharging every 1 to 3 months. So it's
it can be hard
change in how that's sort of taking place. So then you come back, put the device in. When you put the device in, it's 2 cuts. So there's a little incision over the midline where you put the leads, and then one over your buttock or your flank where the IPG goes. It's quite simple. You're not going through anything. You're not going through any organs. So it's generally in soft tissue or placed into fat. So it's quite a simple procedure.
Squished between your muscle and your skin.
Yeah.
I wish there's more soft tissue.
Yeah, you don't have that.
Depends
much
where they put
tissue.
it. I know, it depends.
I'm just going to say most people are okay.
I just wish there was more padding. Yeah, they are all right.
Now, when you do this, as with everything, there's complications.
Complications
so
and
there's
risks.
risks. So risks.
This is the part people get real
infection, bleeding, bruising. You can, particularly for patients that have got pain, like if part of your pain is your back, and I'm going through your back to put in the leads, you can get pain at the site where we put in the leads. And in the setting where you've had a trial, we basically, that'll settle down over 3 or 4 days. We basically will extend the period of trial until that, the flare due to the needles going. And
so you can evaluate it. Yeah. Better. So.
When you're putting in the leads, there's the risk of spinal cord injury. So that is a very rare risk, but it is a risk nonetheless. Within the spinal canal, you have a thing called the dura. So the dura is a sac that sits around the spinal cord. If you put a hole in that sac, it's called a dural puncture. That will then leak, gives you a headache. Generally, the headache will just go away over a couple of days. If it doesn't, we do what's called a blood patch, and that essentially takes it away. It's once again a very rare complication, but is annoying. There is the risk of what's called, with bleeding, it's called spinal cord hematoma, which is a bleed on the inside part of the spinal canal if one of the blood vessels leaks. I've not seen one of those before, but they certainly are possible. Other risks include the leads moving. And so if you fall
or breaking,
and the leads move,
or
you have to go through a process of reprogramming around them.
Or if you don't fall, I don't fall. Yeah. I'm just broke. But that's the common one.
Yeah. So if you move the leads, you reprogram around it, and so that's basically where you shift where the buzzing is taking place, and you try and recapture the pain. Now,
because it's a long enough strip. Yeah. It's a long enough strip where you have some wiggle room.
Yeah. So if alternatively you fall and the leads move inches, well, that just means the leads need to be repositioned, which is annoying, but it is what it is. The other issues that you can get are you can get pain over where the IPG/battery is, which is quite annoying. That's actually relatively common. So 20 to 30% of patients actually experience that. And so it's something that we need to be able to settle down and treat over time.
And we cover some good strategies for treating pocket pain in the Ask Us Anything episode 29, where we actually take a different deep dive into neuromod and get into some of my personal experiences and some of the challenges with compensations around it. And so if you're curious about that and want to look into more of the pocket pain stuff, check out that episode because Dan goes into it in more detail than we do here.
Yeah. And then there's another thing called a seroma. So that's a little collection of fluid at the site. And I tend to see them in the midline over the incision. They come and go, and then they eventually just go. So their annoying management strategy is don't touch them, and they'll go away.
Leave them alone.
All right.
It's the quick and dirty on Neuromod.
That is the quick and dirty on Neuromod. I think the important thing about Neuromod is that it is part of a treatment program. It's not the whole of a treatment program.
Yeah.
And it needs to be incorporated into, your medications, your rehab, your psych, and you put it all together and it can be good. And it's not something to be dismissed, but it's something to go in with, consciously and with thought and with a team around you.
Yeah, it has challenges and issues, but the upsides can be tremendous and more than worth it. So this, like all the other therapies, right patient, right time is key. So a lot of the horror stories you hear around Neuromod, that didn't necessarily happen. Risks are always a part of things, but the upside with this can be life-changing as opposed to with other therapies. It's just not as dramatic of a difference. So evaluate it properly and then make the best decision you can with the information you have at the time.
Yeah.
All right.
All right.
Thanks, Dan. Appreciate it.
Pleasure,
Good tidbits. And we will see you next time on another episode of It's Not in Your Head podcast. Take care.
Okay. Cheers. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.